So I did want to say first, as a member of the planning committee for this session, when you hear about metrics and you think about a whole session, a workshop on metrics, you know, people's eyes start glazing over. But I want to say that this has actually been, at least from my perspective as someone who's interested in metrics, very interesting session. I really enjoyed this so far, and I hope that you have as well. So putting my hat back on as a speaker at the workshop, and a speaker that is standing between you and lunch, I'll get right into it. So there is a small but growing literature on the creation of indices for health equity, or and let me just back up for a moment and support what Steve said, that these issues of equity, equality, disparities, these terms are important. And if we are to first create a purpose, a goal for the metrics before we create the metrics, I think it's important for us to think about what do we mean by these terms and what are we trying to accomplish? Are we trying to accomplish equity? Are we going for equality? Are we looking for inequities? I mean, these are all valuable and valid goals, but they're not the same goal. So I did a study in Baltimore, in fact, in West Baltimore, that community that was redlined and that where the Freddie Gray death occurred, where we looked at racially integrated communities around the country that did not have disparities by race in socioeconomic status, as measured by high school graduation rates and median income. We found that community in Southwest Baltimore and went in and we replicated portions of the protocol from the Health Interview Survey and Haynes. And what we find there is we don't find disparities by race. So we have equity, right? Because the groups are equal. But the groups are equal because the white rates are just as high as the black rates, because anyone living in a community with that set of social characteristics is going to be sick. So race is not protective if you live in an environment that is going to produce bad health outcomes. So equity and equality and disparities are actually not the same thing, and I think that is important, although not the topic of my discussion today. I want to talk a little bit more. Also, there's a small and growing literature on the creation of indices, similar to, I think conceptually similar to measures like the gross domestic product, you know, an important measure which has, as someone said earlier, a huge engine behind the creation of that metric. And I think, although most people couldn't tell you how it's calculated, they do know that it has some meaning, right? So it means something, that number goes up or goes down. It may not mean what we hope it means, but it means something. And there are some people who have argued or tried to develop similar types of metrics to get at health equity, and I have a few of these articles here published. I think few of the references here that you might be interested in, but that's not what I'm going to talk about today either. I'm going to talk about today something that's a little more practical, something a little more on the ground of what we actually do and how we try to express this issue of inequalities through the use of metrics, and some of the potential pitfalls that we fall into by doing the things that we typically do, right? So I'm going to walk you through a few examples of things that we often do. And let me say before I even get started that you will find that I have committed some of the very sins that I'm going to talk about here today. So the point is not that he who's without sin should cast the first stone, but rather that we should repent, go forward, and sin no more. Right? So, okay? So, I did also want to bring to your attention this resource. National Cancer Institute has created a software that's available on the website for free download, and it's done by the Cancer Institute. It was originally created to do analysis of SEER data, but you can actually import other data sets, and I've played around with it a little bit, but not that much yet, but it does seem to be pretty robust and pretty interesting, and you know, you may want to just know that resource exists. So let's move on. This is the quintessential chart showing racial disparities that we use in this country. And this is for 2009, frankly, because I got frustrated in 2009 and said, there's no point in updating this chart anymore because it's the same chart, right? If it was 1999, 89, 79, it would look exactly like this, right? The absolute rates are going down, no doubt, but the relative rates are not changing, right? So there are limits to simply comparing these rates, which is what we typically do. And here's one example of where we have limits and how it could impact our policy development as well as programmatically where we decide to devote our resources. So I've put here just the smoking rates, just the rate of smoking by race for men for 2000, right? And if you look at this chart, you would conclude that there really is a problem here in terms of equity. You might argue that the rates are too high, but you'd say there isn't really a disparity, there isn't a race difference here, and this isn't really something to be addressed from a disparities perspective. But if you were to plot smoking prevalence by age and race, you would see several interesting patterns in this data that have implications for how we intervene and where we devote resources. So you would see that smoking rates are much higher among whites compared to blacks or Latinos in the teenage years. And we see the white rate declines over time, whereas the black rate and the Hispanic rate increases, and especially the black rate begins to increase into adulthood. There is a crossover, and in that crossover, never quite changes. Now, so the phenomena of smoking is something different for the different populations. So for whites, it's youthful experimentation that begins to decline as they move into adulthood. For Latinos and African Americans, especially in this case African Americans, I suspect that what's really happening here is that smoking is a response, is a coping mechanism, a response to stress. So if we're going to craft messages to prevent smoking and to implore people to stop smoking, we would take different strategies, and we would also target people at different points in the life course. Typically, we focus those prevention efforts among teens. Here's a pattern for women, by the way. You see a similar type of phenomena with a dramatic increase in smoking among African American women as well. So simply calculating and comparing rates masks important information that can have implications for policy making. Another issue is social position. I've just put together a few charts here just showing disparities. Here I'm using black and white, and by the way, the years of the data is just based on what data sets happen to be on my hard drive and cleaned and ready to be analyzed. So forgive me for some of the data being old, but I think the points are still the same. So as you go across a variety of health outcomes, we see a similar pattern of socioeconomic status, that is, as education increases, the absolute rate tends to decrease in most cases, but not in every case, but also that there is a racial disparity at all levels of education. But the difference, if we simply eyeball the bars, we see that the difference between the race groups, vary from one condition to the next at different levels, so that the disparity is not consistent. Again, something that would be masked if we simply looked at overall rates and didn't account for the fact that socioeconomic status is an important confounder of any race analysis because of the different distributions of socioeconomic status. Here is some analysis looking at income, and we see a similar phenomena across each of these. Again, not always linear, so increasing income does not in every case lead to decreasing risk. And I want to get to this last chart here, which is really important to look at, that for whites and hypertension, we see the traditional pattern where increasing levels of income leads to decreased risk of hypertension, but for African Americans, we actually see an opposite pattern, but increasing income increases risk of hypertension. So the underlying phenomena is different, and by simply calculating rates, we mask this difference. Now, many of you probably thought to yourself, well, we deal with this issue through multivariate modeling, right? Regression modeling. So let's talk about why regression modeling alone is not enough. So I'm going to do an example. I'm going to use a 2005 National Health Interview Survey. I'm going to use all of the adults of age 40 or older, of which there are over 33,000 people in the case, so cases in this data set. So we're using a big data set, and we're using a health interview survey. So this is the official record of the health of the U.S. population, right? This is as official as you can get. Right? So I'm not gaming this at all. We're going to do a very simple analysis of comparing blacks and whites, looking at race differences in, let me just bring the whole thing up here, race differences in having at least one ADL. ADL is activities of daily living, a measure of physical functioning, and one ADL would be, I think, setting the bar pretty low, right? Can I get agreement here, right? All right? So I'm set the bar low. I'm not trying to trick anyone. Income is in three categories: under 20,000, 20 to 75,000 and above, and then 75,000 and above, right? And you see the sample sizes, right? So what do we do? So Biostatistics 101 class, what we do is we first look at the bivariate relationship between race and ADL limitation. Here I'm using logistic regression. We get an odds ratio of 1.46. Confidence interval tells us that this is significant. So we conclude African Americans 46% greater odds of having one ADL limitation compared to whites. Am I right? Right? Come on, if we're going to make it to lunch, you're going to have to give me. I know we're not in church, but so I call and you do what? Okay, so you know what you're supposed to do, right? So behave. All right. So far, there you go. So I'm passing Biostats 101 so far, right? It's good to know I can still do that. So the next thing we do is look at the relationship between income and ADL limitation. So as we see, the odds ratio is declining as income increases. Confidence interval again tells us that this is significant. So far everything is operating as we would expect. So what's our 102 class? We put income and race together and we see what happens. So we do that, and here's what happens. First, let's look at income. The income effect persists, right? As income increases, the odds ratio decreases, and it is significant. But what happens to the race effect? It's no longer significant. So what do we do next? Well, we write the paper, we publish the article, and right? And all is right with the world, right? Except that we've now added false information to the research literature. Because if we had simply arrayed the data by race and income and looked within each cell at what is the rate of ADL limitation, one ADL limitation, we would find something is more, there's something more complex than nuanced. In the lowest income category of 20,000 or lower, we see that there is, in fact, a significant race difference, so something is going on there, right? We would also see that in the highest income category, $75,000 or more, that the rate for African Americans is being calculated on a basis of 8 events. So in the National Health Interview Survey, one of the biggest data sets we have, there are only 8 African Americans with incomes over $75,000 that have at least one ADL limitation. We cannot do this simple analysis in this. Am I scaring some of you? I know, right. Now, this is a dramatically underspecified model, right? So we would need to, in reality, add more variables to this, which would do what? Cut the data into even smaller cells, right? So any analytic trick that I know to make this analysis work would actually require a bigger data set, not a larger data set. So how many papers have you read on race disparities with smaller data sets, much more complex analysis? How many of us have published those papers ourselves? I will admit to have done it. This is my sin that I'm admitting to. So repent and sin no more. Right? Right, so simple regression models do not resolve this problem. One of the biggest issues with addressing race disparities is racial residential segregation and the fact that we live in the country together, but we experience the country very differently because our risk environment is so different. So the index of dissimilarity, which is an index that I won't try to explain here, but many of you, I'm sure, are familiar with this index, is an index used to rank geographic areas. mostly cities or statistical metropolitan statistical areas, on a range ranging from 0 to 100, and it's measuring the degree to which census tracts within the city are racially integrated, right? So basically it tells you a score of 100 means that the city is perfectly segregated, right? That there is no census tract in which people of different race groups live together. A score of 0 means that it's perfect integration. So if the city is 10% Latino, then that means that there's a 10% Latino population in every census tract, right? That would be complete and perfect integration. So when we plot all U.S. cities with a population of 100,000 or more by an index of dissimilarity, and here we're doing it black to white, we see that the mean in 2010 is 0.57, meaning 57% segregated. But if you look at the spread, we see that there's dramatic variation across the cities and the amount of racial segregation that we have, which means that if we simply look at one statistic, one national number, right, it would be like turning on the TV in the morning for watching Good Morning America, and they're telling you that the average temperature for today will be 42 degrees. Doesn't tell you whether you need a coat in San Diego or an umbrella in Seattle, right? It's not a very valuable number. This is the chart for Hispanics to whites, and we see a similar pattern. So now, the limits of relative risk. So I'm sure you've seen this type of chart many times. So, and this is the way it usually goes. Looking at race differences in infant mortality rates between 1950 and, 2004, we see that the disparity has actually been increasing because the ratio has been increasing. Now this misuse of risk ratios is very common and problematic, and let me explain why. So this is just something I came up with on the plane flying out here that I think would help to illustrate this. So let's say we have a statistic, and this is the pattern. We're looking at this statistic over time from 1960 to 2005, and we see that we have a race difference of about 50, whatever, deaths per 1,000 or whatever this is, right? Both populations have been decreasing by 10 deaths, right? The rate has been decreasing by 10 every 5 years. We calculate a difference score, and we see that the difference remains at 50. If we calculate the rate ratio, we see that the disparity has actually increased from 1.5 to 6 if we relied on a rate ratio, right? Now, this is a simple math problem, but this is what happens when we try to use a rate ratio to look at trend data, and this is something that we really must stop doing without providing the full context of the absolute difference in addition to the relative difference. So, as I mentioned earlier, there are some indices that are out there, and I'm running out of time, so I won't be able to go through each of these, but I think these indexes try to get around some of these problems, except they don't all, in every case, they don't succeed at doing that. Relative risk or use of relative rates has this problem with trends. If you simply try to standardize based on comparisons to a mean, for example, the Field Index, which looks at variation from a population average, the problem is that the population average is also dynamic. So if you want to plot that over time, you're going to have the same problem of the rates potentially being biased if that mean is not changing. So this is something else I put together here, just looking at an alternative way of approaching it, and I think is effective from a public policy standpoint in the sense that it is intuitive. You can look at excess deaths. So if you say Asian Americans have the lowest death rate, if every other racial ethnic group had the Asian American death rate, how many deaths would have occurred, right? Or in this case, how many fewer deaths would have occurred? And that's what I've plotted here. This is absolute number of deaths. You can also plot that by looking at deaths per 1,000 persons. So this is relative to the total population, which I think creates a more accurate picture of the disparities. You could also present it, and I think I have found this to be pretty effective with policymakers because it's intuitive. If you said, okay, what percentage of the total deaths that occurred that year could be considered excess deaths? Okay, so what's the proportion of the deaths that maybe would not have happened if the rate for everyone was equal to the group with the best rate, which is Asian Americans, and that's what this does. So finally, another approach that I found is that sometimes is to move away from health metrics entirely, and this is from a report that I published a few years ago where we calculated the economic impact of health inequalities, the cost to the U.S. economy. And we did that in 3 areas. We looked at death from premature, cost of premature death, use of direct medical care resources, and then also indirect costs in terms of lost productivity to the economy. We calculated that at $1.24 trillion over 4 years lost to the U.S. economy. And then finally, many of you on the roundtable know that I am working on a documentary on African American health. And that's all part of a large community engagement program. And when you talk to people in communities, it's very difficult to talk about these statistics in ways that they really understand. So the statistic that I like to use when I'm talking to general population is life expectancy, because it's where the rubber meets the road. That when I graduated from graduate school, got my PhD at 1988, the disparity between white and black Americans in life expectancy was about 5 to 6 years. When I published my first article was about 5 to 6 years. When I published my 100th article, it was 5 to 6 years. Now, I could publish 100 more articles probably, if I can live long enough. But I suspect if I did that, the disparity would be 5 to 6 years. So the idea is to try to do something different. So we're doing this film project. And when we go out into communities and talk to people, we tell them that. And when you say 5 to 6 years, people don't really react to it. But then when you say, what could you do with 6 additional years of life? Then it gets real. It gets real. And I was in Brooklyn last week. In fact, I noticed on the map that Steve put up, it showed the community Brownsville, which had the lowest life expectancy. It happens to also be the neighborhood that I grew up in Brooklyn. And I was back there last week doing some taping for the film, and was talking to some of the people in the community. And this woman in a wheelchair came up to talk to me about what's this about? What are you guys doing? And I told her about the 6 years. And I asked her, what would 6 additional years of life mean to you? And her reaction was, in 6 years, there could be a cure. Thank you.